Welcome back. We're going to carry on the third part of this lecture, talking about on anterior segment disease, talking about cataracts. So the understanding the anatomy of the lens helps us in diagnosis, and also an understanding of progression of disease and pathology in the lens in all our patients. So the lens is a beautifully designed part of our body. It's uniquely transparent, and also we're uniquely able to change its shape to focus light. This is a very simplified diagram taken from a great online resource called OphthoBook, which is used for human cataract surgeon training largely. And what we have is an external capsule, which is the basement membrane of the epithelial cells, which line and fill the lens itself. And we have our actively replicating lens epithelial cells in the cortex, which is underneath the capsule, but also filling the lens up until the nucleus with all the lens which has been formed during our adult lives. And in the central part of the lens, the nucleus is the part of the lens which was formed in utero. I like to think of it anatomically like a peanut M&M with a candy shell, analogous to our capsule, the lovely squidgy chocolatey bed, which is equivalent to our soft squidgy cortex, and then the harder, denser peanut or nucleus, which as we age becomes smaller and smaller and denser and responsible for the bluing we see in many older dogs' eyes. The function of the lens is to form a focused image, and that is both close to and also far away, and the ability to be able to change from focusing close to us and then far away is called adaptation, and we rely on the sonnual fibers and the muscles in the ciliary body to pull our lens to stretch and change shape, which alters as we age, and why many of us need reading glasses by the time we're in our late 40s and 50s. We've seen this dissection in our previous lecture. Previous part of the lecture, which is our evisceration preparation, and we see the uveal tract beautifully laid out, and also the lens, which is huge in the dog, sitting separate to the uveal tract. The lens is beautifully transparent, as you might imagine, and will magnify as it focuses light. As you can see in this image, we can see the magnified gauze through our extracted lens from another dissection. When we squish the lens and the capsule is snapped, we can see the lamellar structure of the eye of the lens becoming apparent. The lens is formed from sheets or lamellae of lens epithelial cells, and they have a beautiful protein called the crystallin, which allows it to organize itself in such a way as to allow light to pass through it unobstructed. So in one cross-section, we can think of it like an onion with concentric rings, and another cross-section, we can think of it like a orange with segments leading front to back. So this shows us this lovely lamellar arrangement. This gives us a side view of another dissection. We've removed the lens capsule, and the alcohol we used to prepare the lens is causing the lens fibers to start to peel away. We see each one of these sheets of lens lamellae is made up of individual fibers, and we can appreciate how as the lens fibers moving front to back, it forms segments or wedges. In our patients, mostly that is 3 wedges to give us the joint together to form the suture lines front and back. The lens is an epithelial structure, so embryologically it starts as a lens placode, a flat area of the embryo, and the basement membrane of the epithelial cells it forms the lens capsule. So this flat lens placode will turn itself around to form the lens vesicle, which will then fill up slowly with lens epithelial cells. But the important point is that the lens capsule is the basement membrane, is an acellular part of the lens. And these basal epithelial cells are very well attached to it, which is important in cataract surgery when we come to remove the lens fibers. So as the lens placode develops, the developing lens will fill with epithelial cells, and at birth we see an arrestation of the continued development of lens fibers, which we can actually see clinically as a separation between the embryonal nucleus, which as our patients age will become smaller and smaller as it's compressed by the continual production of cortical lens material. So this lamellar structure allows us to interpret lens lesions and make a good guess as to the chronology of what's happened in the eye. You can think of it in many ways as similar to what happens in a tree trunk. We know that trees develop each year of growth or lay down a new ring, and we can usually see a demarcation between each season as we have arrestation of development during the winter months normally. And the oldest part of the tree, the sapling, is right in the middle. The newest part of the tree is just beneath the bark equatorially, and the bark, like our lens capsule, is dead tissue, and the living part of the tree is just beneath the bark, just like in our lens. The living part of the lens are the epithelial cells, which are sat just beneath the basal epithelial cells, just beneath the equator of the lens. So the image beneath shows us an older dog. We can see just about make out some concentric rings to show us the central nucleus and the peripheral cortex. And in the cortex, we can see these white opacities. And this tells us these opacities are formed in the developing lens, and therefore more likely to be recent. These are actually spoke cataracts in an elderly dog, so a senile change. Top right image, you see lots of a complex change. We've got a central part of our lens. The nucleus is a dense cataract. And this part of the lens forms in utero, and then the equatorial lens is still transparent largely, the cortex, and we can see within it these lovely vesicles, these lens vacuoles forming, which are new lens fibers forming but becoming abnormal and bloated. So lens vacuoles in the equator are generally a sign of progressive cataract formation. In the bottom right picture, we see a Jersey cow, and we can see a capacity right in the central pupil with using an oblique light to localize it. We'd localize that to the nucleus, and that tells us that this lesion almost certainly formed in utero, so it's a congenital cataract in a cow. So what are cataracts? We're going to run through what they are, and we talk about what causes them. Then we talk a bit about surgery. Cataract surgery is the only route to vision for blinding cataracts in our patients, and sadly there are no medical treatments available yet. It's an expensive procedure for a very good reason, because it's expensive in time and equipment. So that also then leads to some problems as clinicians as to what do we do when our patients can't afford referral for cataract surgery. So we can talk a bit about what to do if we can't do surgery. So what do we do if we don't? What are the implications if we don't do cataract surgery? Talk about case selection, and then what we're going to run through what happens in cataract surgery itself. So what are cataracts? A cataract is any opacity within the lens structure which blocks light. It comes from the word, similar word we use cataract in, we refer to running water, and a cataract is that white foamy water where we lose the transparency of water because of all the bubbles. So in this top left image is an old video capture. Nowadays we'd use iPhones to picture or retinal cameras to capture the lens. And we can see that there's a yellow to pupil reflection, so some light is passing through the lens and going back to us, but there's also these black linear shadows, which are opacities, and these mimic the suture lines in this dog, both front and back overlying each other. This is an immature cataract. This dog can still see a moving hand in front of its eye. When we use a lens to look at the retina, we can still just about make out a retinal detail, but these are cataracts. It's the black area is the light being blocked as it reflects from the beta. Top right image is from an older dog. We can just about see a concentric ring in the middle of the pupil. This is the difference between the nucleus and the equator. This dog's got nuclear sclerosis, but there's no shadowing, there's no opacity, nothing blocking the light, apart from just dorsally we can see this iris cyst, which is causing an issue. So ignore that for now. When we look at this dog's fundus, we can see clearly the dog's retina. Cataracts go through life cycles. They start as incipient, so there's capacity there with nothing to obstruct visualization of the retina or probably vision, due to immature forms where, such as this tiger here, blotch, and then to maturity, where actually we lose all reflected light and see no retinal detail. This isn't just a mature lens, this is a mature swollen lens, and we can see the lens sutures have been shifted from the center off to dorsolaterally, and they've become separated, something we call water clefting, and this is typical of a rapidly swelling or intumescent cataract, which you would typically see in diabetes. These lenses can double in volume and rupture quite quickly. This lens is suture have moved from the normal axial position, which makes us worry that this lens may have ruptured and the lens contents are starting to move. With time, abnormal lens cataractous lens fibers will start to dissolve and leaving a hard nubbin of cataractous material, becoming a hypermature cataract, such as in this right-hand image. So what causes cataracts? So congenital cataracts formed at birth can either be inherited or formed by teratogens during birth. So in the cow, for example, BVD would be a common cause. We rarely recognise specific teratogens in dogs as a cause of nuclear cataracts, and most of them are assumed to either be inherited or due to illness during pregnancy. So congenital nuclear cataracts tend to be will always be nuclear. Nutrition, the wrong sort of milk replacer can lead to effectively diabetic sorts of cataracts. This is a tiger who was fed bovine milk replacer through his formative years. This leads to an abnormal increase in the wrong sorts of sugar inside the eye, which haven't got the right enzymes to deal with these sugars will build up in the lens themselves and become osmotically active and allow water to move into the lens and separate lens fibers and lead to cataract formation. Which leads us nicely on to diabetes, which we see commonly in our canine patients. This is obviously a ferret, which also gets diabetes as well, and develop diabetic cataracts. Diabetic cataracts are very, very common. It's hard to say whether the control of diabetes will make a substantive difference to when cataracts will develop. Logically, you might imagine that well-controlled diabetics would progress to cataract formation later in life, which doesn't seem to be clear cut as that. We expect every canine patient to develop cataract at some point if they survive long enough. So when you diagnose canine diabetes, it's important to mention diabetes and to mention that cataracts can come on very quickly, and the decision to go to surgery will very quickly will better the outcome. So understanding the importance of ringing the vets at the first sign of cataract, and also having a financial plan to support cataract surgery should that happen at an early stage is very important. One of the key worries we have with diabetic cataracts is the fact they can come on so suddenly. They can go blind overnight, and these lenses can double in volume. And once the lenses have ruptured, the short-term complication of surgeries in surgery is that the surgery can be much longer. It may not be possible to place an intraocular lens. Long-term ruptured lenses can lead to acute and chronic lens-induced uveitis, round detachment, glaucoma, and blindness. So early surgery is very important. Trauma to the lens, so particularly damage to the lens capsule, to allow those lens proteins to become exposed to the intraocular immune system and lens-induced uveitis, but also physical expulsion of lens material into the eye can be rapidly damaging to the eye and can lead to retinal detachment and glaucoma. This is a dog who's had a cat scratch, a common cause of lens perforation, but perhaps less typically, the cat's claw went through the white of the eye, through the sclera, and caught the edge of the lens, as opposed to more not typically through the cornea. So just because if you can't see a corneal lesion, just remember that cat claws can go through the white of the eye, often through the skin and through the white of the eye. Often it's more obvious, such as Julio here, who's got a blackthorn little cat, gone through his cornea, impaling his lens. We mentioned in uveitis that inflammatory changes in the anterior uvea and the posterior uvea can affect the lens epithelial cells. And this is a horse who's during recovery appeared from acute uveitis, has gone on to develop subcapsular cataracts. These beautiful floriform cataracts here. This is just one lamellae thick, just beneath the anterior lens capsule. This horse it's got a very dark iris and shriveled granular indica, and this dark iris has a loss of iris architecture as well. It's very smooth in appearance. It's typical of a patient who's had chronic uveitis, and this horse has had chronic uveitis with acute flare-ups of acute anterior uveitis, a condition we call equine recurrent uveitis, ERU. Posterior changes can also lead to cataract formation, so retinal degeneration of all forms actually can lead to secondary cataract formation. PRA is an inherited, slowly progressive or variably progressive depending on breed, cause of retinal degeneration and blindness. As the retina dies, we see an increase, we presume there's an increase in toxins in the vitreous, which lead to secondary cataract formation. But often the cataracts form after functional blindness has occurred. There are some breeds where functional blindness is delayed, and the cataracts will form while there's still potential for vision. And in those small number of cases, removing of the cataracts can actually restore vision for the last few years before those retinas finally go on to give up the ghost permanently. Lens-induced uveitis we've mentioned a few times now, and this is a patient. They can do this is a more unusual form, I guess. This is a patient we met as a youngster who had cataracts. He had a partial retinal detachment, so we didn't go ahead and operate on this side, we did on the other, and then we had to manage the lens-induced uveitis as the cataract developed to full maturity and then started to shrivel up and become hypermature, and those lens proteins, as they broke down into smaller subunits, leaked across the lens capsule into the eye, causing chronic low-grade uveitis. So this little dog had been on topical steroids and systemic non-steroidals for the whole of his life, and this is now a 12-year-old dog, and the lens capsule has the lens has shriveled up so much that the anterior and posterior lens capsules actually meet, and you can see a green to beta reflection again. There's a few accretions of lens material within the remaining lens capsule, and this dog actually regained some sort of vision in his later years. And the very last part of his life, he did develop severe lens-induced uveitis as we had to withdraw the systemic non-steroidals and topical steroids, and then actually sadly this eye was lost. There were a few years before that where he did regain vision. You can see his iris is again almost black due to the chronic lens-induced uveitis, but there's no dyschorrhea, there's no synechia. The pupil hasn't stuck to the lens, there's no iris rest, because we managed to control those acute uveitic bouts with topical steroids and systemic non-steroidals. Sadly, that's not often the case, and more often this is the sort of situation we dealt with where we have synechia, secondary glaucoma, and a blind, painful, uncomfortable eye. So why do we get lens-induced uveitis? We mentioned it before that really the key to uveitis will always be this breakdown of this immune privilege, and that the immune privilege is maintained between the eye and the rest of the body by the blood-ocular barrier, which is a vascular function. This picture right to remind me to tell you that the eye is a very fragile organ. This is someone who took their camera paintballing, which is not advised. And being such a fragile organ, any inflammation inside the eye can be potentially blinding, going on to cause cataract or glaucoma, for example. So at its basis, uveitis generally is bred in the blood-ocular barrier. However, the lens-induced uveitis is perhaps a little bit different. Though the inside of the eye and the surface actually is immune privileged, within the eye, the lens is a little enclave. So the intraocular immune system is unaware that there is lens material, isn't exposed to the crystallines within the lens capsule. So if you have an intact blood-ocular barrier, so that the inside, so it's really only the intraocular immune system we have to worry about, then as the lens starts to dissolve slowly, you often get a chronic, very low-grade uveitis caused by intraocular immune reaction to the lens proteins. However, if you've got a damaged blood-ocular barrier, so for example, a dog who's got chronic dental disease and chronic bacteremia, then when you develop cataracts, your lens-induced uveitis is much more severe. So there's almost two. This is an enclave with this immune privileged site within an immune privileged site. So you can think of the intraocular lens or the intraocular environment as this is the Angkor Wat, a Buddhist temple in Cambodia. I had the privilege of visiting many years ago. It's a beautiful, peaceful place, and there are people around. There are Buddhist monks who are just gently keeping things under control, but it's not got the aggressive immune system. There's no police or armed forces looking after the immune status of the eye. The immune system is very gentle and calm, and all about keeping the intraocular environment as quiet and transparent as possible. So we talked about what do we do when we don't think surgery is an option. So if we don't do surgery, then our long-term concern is lens-induced uveitis if the lens progresses to maturity and then hypermaturity. Not all cataracts do that. Some cataracts will be focal and never develop secondary lens-induced uveitis. However, mature cataracts we would expect to. And lens-induced uveitis, of course, the chronic inflammation can lead to glaucoma around detachment and ultimately nucleation if that can't be controlled, with no visual prognosis effectively in those patients. Surgery is not without risk. By opening the lens capsule, we can also stimulate lens-induced uveitis, and that can go on to cause glaucoma around detachment and nucleation. However, the difference is early surgery has a very good prognosis, and that visual outcomes are well over 90% in early operated cases. Where cases have already got lens-induced uveitis or other intraocular disease, visual prognosis is much poorer. Lens-induced uveitis can be more subtle or can be more obvious. This is a dog referred to for cataract surgery a long time ago. In his left eye, we've got a smoothing of the iris architecture. You can see the edge of his iris is rolled inwards, entropia uvei. There's quite a smooth appearance to his iris surface. He's got a few bits of pigment on his anterior lens capsule. So this is a chronic change, and this has had a Dazzle and a normal electroretinogram. And though cataract surgery was performed, but we had grave concerns about the long-term inflammatory ongoing inflammatory problems caused by the pre-existing lens-induced uveitis even after the lens was removed. The other eye had more active changes, actually blood, and there's actually some vitreous here coming through and trapping the blood. And this lens is more of in more trouble, and the eye's in more trouble. This eye actually had a retinal detachment as well and wasn't operable. Sometimes it's more obvious. This is Bozzer, who again was referred to cataract surgery. His right eye, both eyes have got black irises caused by chronic lens-induced uveitis, telling us these cataracts have been here for a long time. The right eye, you can see, is actually slightly larger. There's episcleral congestion, pancorneal edema, and this eye sadly got secondary glaucoma. Neither eye were operable. Both eyes had retinal detachment. Some were blind, and this Bozzer had bilateral nucleation. Cataracts, we mentioned, particularly in diabetes, can swell very rapidly, and if they swell rapidly like a ripe tomato, they can split. And this is another patient for cataract surgery many years ago. In the left eye, we can see the suture lines have been separated, called water clefting, which tells us this lens has swollen. The other eye had actually swollen, had actually ruptured at surgery, and unusually had ruptured into the anterior segment. Normally, these rupture posteriorly into the back of the eye and are less obvious. Both eyes were inoperable actually, because both eyes had retinal detachment. So what do we do when we come to surgery? The pre-surgical screening is very important. We look at general health of the patient. But we don't, vision is important, but not more important than patient's health. And most of our patients can survive very well as blind pets. Temperament's important. There's lots of aftercare, lots of eye drops, lots of visits to the vet. So you have to think very carefully about whether that's your dog or cat is the right temperament for surgery. Some of your owner's commitment, be it financial or time resources. And these are screening questions we can think of even before they come to us. Then we have to ask ourselves the most important question, I guess, is will removing the cataract surgery restore vision if the retina is dead? Removing the cataracts will not help. So we would never remove a lens from a blind eye in order to prevent lens-induced uveitis, for example. We would treat that medically until the iris needs to be removed. Then we'd ask, is the patient healthy enough? So what are the health risks? So an older patient or diabetic patients often may have comorbidities. And then we'll ask, is the eye itself up to it? Is there dry eye? Is there secondary glaucoma? Is there an abnormal drainage angle which may predispose to secondary glaucoma? And those are the general questions we're asking in our screening, but the actual screening processes we'll run through now. So the first thing would be a full eye exam after a full clinical exam, which for us would include cystocentesis to look for occult UTIs, bloods, conjunctival cytology and culture to look for bacterial and to assess the bacterial flora. And during the eye exam, we assess temperament, look at tear production, intraocular pressure, look at the cornea very carefully because there's lots of drops after surgery. We want to know if there's any uveitis, both chronic and acute. Any acute inflammation we want to get rid of prior to surgery, and then we also want to immunosuppress the eye prior to surgery to reduce the risk of severe postoperative inflammation. We stage the cataract, which helps us to work out whether we need to operate now or later, and also assess our risk of LIU. And then we assess vision. We talked to the owner about a history of night blindness or nyctalopia. It's one of the cardinal signs of PRA, which, as you mentioned, can go on to cause cataract. And then we will assess retinal function using usually electroretinogram and sedation. We will measure electrical activity of the retina, but prior to that, we'll do the Dazzle test, Dazzle reflex, which is shining a very bright light, looking for an aversive response. This is a horse with a mature cataract, and you can see that when we shine the very bright light, we have an obvious blink. So Dazzle reflex is a very simple test. If you're presented with a cataract patient and there's no Dazzle reflex, that's a poor prognostic indicator. Glaucoma is the biggest, single biggest concern post-surgery, actually, of all our patients, both short, medium, and long term. So assessing that glaucoma risk helps to counsel the owner, and also may decide whether we do ECP at the time of surgery, for example. So measuring pressures important, but also assessing the drainage angle. This normal drainage angle above is what we want to see. We don't want to see a closed angle here with pupil iris going down to meet the cornea coming straight up with no drainage angle to see. We use a gonio lens, which is placed on the surface of the cornea, and using a slit lamp will examine the drainage angle when they're going to make an assessment as to whether we think the risk of primary glaucoma is great in this patient or not. All patients will have an ultrasound, looking for signs of retinal detachment. Particularly, we look at the retinal insertion, looking for areas of abnormality there. We assess the vitreous to look for whether the vitreous is still attached to the retina. So if not, we see what's called a posterior vitreal detachment, which we know will increase our risk of retinal detachment. We assess the lens size and shape, looking for signs of rupture, which may lead us to delay surgery or immunosuppress the patient if it's already ruptured, or if it's about to rupture, may move us towards emergency surgery to get us into theatre straight away before it ruptures, and obviously look for tumours, which are unusual. The ERG allows us to quantify the function of the retina. It's not a test of vision. All it is a test to can the retina turn light into electricity. So a dog with an optic nerve, optic neuritis, or an optic nerve compressive lesion, they have a normal ERG but blind. But for us, it's as good as we can currently get to assess, to guess whether these patients will be visual afterwards. So we will assess retinal function with these electrodes on the surface of the cornea. We flash lights in the eye, and we pick up an electrical activity recorded by the retina. Following this, we'll also do a visual evoked potential. So we'll actually record with electrodes from the base over the occipital cortex to see if we can actually get retinal activity recorded at the level of the brain, and that gives even more reassurance. These dogs or cats or rabbits will be visual afterwards. We met this little dog already. This is who's blind with PRA and secondary cataract. This is a normal ERG on the top with a normal A wave and B wave. We measure the height of this A wave B wave complex. And this is his ERG, which is electrically dead. It's a flat line, so there's no point removing the cataracts, as we will not expect to return vision. And we pre-treat the eye by immunosuppressing it usually with topical prednisolone and with systemic anti-inflammatories, usually meloxicam or similar. We improve the corneal health if needed, so these dogs will have a topical preservative-free hyaluronate before surgery, which helps to assess whether they're able to tolerate medication. And we try to pre-treat for at least 7 days. Sometimes when we know there's an existing lens rupture, we may add in oral cyclosporin, which seems to help in these cases. Surgery itself is effectively microsurgical keyhole surgery through small corneal incisions. We peel away the central part of the anterior lens capsule. We then remove the hard nucleus, and then with a phacoemulsification, this little needle has to vibrate very, very fast, like a jackhammer, and emulsifies the proteins, which then are liquefied and sucked up through the needle itself. The squidgy cortex, the chocolate peanut M&M, doesn't need emulsification; it can just be sucked out with aspiration. And then the empty lens capsule, if it's intact, will allow us to place the artificial lens inside it. What that looks like, this is a small video from some of our early patients. So we use different instrumentation now, but it's a similar process. We make a small incision, we dilate the pupil with adrenaline, we then stain the capsule with a drug called trypan blue, which allows us to see the capsule, but also to help it tear more predictably. We fill the eye with a viscoelastic made of hyaluronic acid, and we have various sorts and combinations we use for different patients to protect their endothelium in their cornea, for example, if that's a risk. We then make a larger incision to allow our phaco needle to enter the eye. We use scissors and small forceps to cut a circular, to tear a circular hole in the anterior lens capsule, the capsula rexus. Then we progress to our sculpting phase. So using our phaco needle, we'll sculpt our hard nucleus, often into 4 segments, but not always. And each of those segments is then removed. Separately, here's us removing the remains of the nucleus. You can see the lens fragments are being sucked towards the lens capsule, so the needle tip, sorry, and then they are, as it's turned on, they suddenly turn to a liquid, a milk, lens milk, hence phaco lens emulsification, and we can see the retina starting to appear behind the removed lens. To remove the cortex, we say we don't need phacoemulsification, we just need to suck it out with aspiration. And then finally, we place our intraocular lens. We have approximately 10 different sorts of intraocular lenses, different sizes, shapes, materials, which we use for different shaped eyes, different disease processes. These often we use a foldable lens. This is a foldable lens. These lenses are folded into a insert. You see this has got posterior angulation, it's not flat, and the posterior angulation allows the optic to be pushed against the posterior lens capsule. It's folded into an inserter that's injected into the eye and slowly injected, and then it unfolds into the lens, capsule itself. So you can see the lens, there's a few bubbles there, but we can see the lens moving down the inserter into the lens capsule. And then as we withdraw the lens inserter, you'll see the lens, intraocular lens unfolding expanding into the bag itself. So lots of different sorts of lenses. We tend to use what are called plate haptics. The central part of the lens is the optic, the arms called haptics. We tend to use large plate haptics, which means that if you need to go in the eye with a laser to reattach the retina afterwards, or stop retinal detachment, we can actually laser through these plate haptics. We have in the past used these Fresnel lenses, which allow us to have larger optics, larger central focusing parts, but much thinner, using this Fresnel technique where we have grooves cut in them. We tend to use those less now because as retinal reattachment surgery is more part of what we do should we hit problems, and these lenses are a little more problematic to deal with. They are very helpful in very large animals. This is a horse. The horse's lens is enormous, and then the only way we can get an IOL into that eye is to have a Fresnel lens, Fresnel type lens. Very beautiful piece of engineering. Why do we use it? Visual outcomes of that, IOLs are significantly poorer. Dogs would be legally blind. They wouldn't be able to read, for example, without an IOL, apart from certain circumstances. And we certainly see an increased quality of life in dogs who have IOLs. That said, a good aphakic surgery, so a surgery which hasn't damaged the eye and it's not possible to put an IOL in, those dogs are much better off than a dog who's had an IOL placed and actually had other complications. So it's not always as simple as you have to have an IOL, but in general, we would always aim to do so. This gives an indication of what we would see. Dogs are red-green colourblind. They wouldn't see the beautiful colours we see. The top left, they would see a more muted colour range at the bottom left. With their cataracts, they would really see very little of the world, just shapes and shadows. And without an IOL, they would be able to see the world around them, but a very fuzzy view. So definitely an improvement without an IOL, but our preference would be to give, we always aim to give normal vision to our patients where possible. So just a quick summary before we finish the anterior segment lecture. Uveitis, always think systemic disease. Glaucoma is bad news. You need to be able to measure the pressure and to be able to seek early expert advice as to which direction to take. Cataracts, always earlier operated, or certainly the earliest assessed, the better. What we're really battling with cataracts is that we're battling this development of lens-induced uveitis, because once developed, it really is there for life, and most of these patients would then need long-term, if not lifelong, surgery and long-term management. This is important as early surgery for good outcomes. So that's the end of the anterior segment lecture. We're just going to take another quick break, and we'll finish up talking about the posterior segment. Thank you.